Thank you, Joe. Good afternoon, everyone. Thank you for joining me as we talk a little bit about how we can help family members of someone who's struggling with a substance use disorder. As Joe mentioned, you can submit questions anytime during the presentation, and we'll take some time towards the end, and I'll answer those as needed. So today I'm going to talk a little bit of the program we have here at the Alltyr Clinic, which we entitled FAMCO. It's our training for family and concerned others with the substance use disorder. So the first section will be an introduction to CRAFT, which is the theoretical model underpinning
If you made a resolution
the
to get rid of a
class.
muffin top or
And then I'll talk about how we break it down week to week, share with you how we participate with our family members there during the weekly class, and share some time for questions and answers at the end. Just real briefly on who I am. I'm an LPC and an LADC working here at Alltyr. I have a master's degree from the University of Minnesota in their integrated behavioral health program. And I'm also a former research assistant at MinCam, which is, of course, the entity putting on today's presentation. The Alltyr Clinic is located downtown St. Paul. Some of you may have heard of us. We're owned and directed by Dr. Mark Willenbring. And we're a small clinic with 3 therapists and 2 psychiatrists and 1 nurse on staff. Our focus is on patients with addiction and co-occurring mental health disorders. We're not 12-step based, and most of our patients participate in weekly appointments and also med checks with their psychiatrist as needed. Here's the contact for me and also the clinic. I'm happy to take emails or phone calls in the following days or weeks if you'd like to follow up with any questions after today's presentation. So this is a really exciting time, I feel, to be in the substance use field. There's a lot of advances in research and professional knowledge. There's transformation in the way we deliver services away from some of the very standard previous models, development of evidence-based practices and additional clinical tools. Hopefully the end result of all this is we're able to serve more people and serve them more effectively. One of the approaches that we use at Alltyr, and which is being utilized more and more often, is a shift from the acute inpatient 28-day stay model to a more chronic and longitudinal care model. So at our clinic, our patients don't enter with any time-limited treatment time frame. We see them as long as they need us. We have many patients who return periodically down through the months or years after their initial round of treatment is over. Some of the other things going on in the substance use field, obviously one of the most important is the integration with mental health and substance use disorder care, the advances in neuroscience, recovery-oriented systems of care. As some of you may know, DHS just merged their mental health and addiction divisions. There's also an increase in the use of harm reduction or third wave addiction treatments, as well as trauma-informed care. So patients with a substance use disorder obviously need the support of their families. The families really are on the journey together, experiencing the positive aspects of recovery and the difficult challenges. So despite the need, for more evidence-based training, many treatment providers' family programs are still based on many of the long-held concepts such as family disease, codependence, enabling, and denial. We've tried to move beyond some of those older concepts and introduce a more evidence-based program for families. So the theoretical underpinning of the FAMCO program is CRAFT, which stands for Community Reinforcement and Family Training. Basically, it's a way to teach family and friends strategies to help them as they work with their loved one to help change the behavior and also feel better themselves. That's the family members. CRAFT works to influence a loved one's behavior by changing the way that the family interacts with them. The families that we work with love being told that they can use empathy, kindness, and love in a way that's supported by research and is actually effective. We don't stress letting patients hit bottom before seeking help. And we've gotten a great response from family members because many folks come to us after having had their loved ones in different treatment programs, and they're really searching for new ideas. So the main goals of CRAFT are to help a loved one move towards treatment. That's one of the defining features of CRAFT and our FAMCO program, is that one of the goals is to get their loved one engaged in treatment. The second goal is to help the loved one reduce their use, whether or not they're engaged in treatment. Many of the family members that take our class have their loved one in our clinic already, but many don't. And there's a lot of the components of our training that can help them influence their loved one's use, even if they don't engage in formal treatment. And then the third goal is to help improve the lives of the family members, whether or not their loved one is engaged in any kind of treatment. The background on CRAFT was developed by Drs. Robert Myers and Jane Ellen Smith at the University of New Mexico. It's evidence-based, and it's the approach to training family and concerned others to enhance their loved one's motivation to enter treatment or to get help in any way and reduce their use. It's a skills-based program to improve communication and change the way families interact with their loved one. It uses strategies to reward desired behaviors and disincentivize undesired behaviors. It teaches families how to influence their loved one while avoiding both detachment and confrontation. And it's shown to be very effective in engaging loved ones in treatment and decreasing their use. Research shows that the CRAFT model has a 64% success rate at moving loved ones towards treatment versus a standard confrontation or intervention, which is shown to have about a 23% efficacy, or if the family members are just engaged in Al-Anon without any other techniques, that's shown to be about 13% effective in moving a loved one towards treatment. I'm not going to try and play this embedded video. It's from the Center for Motivation and Change. We don't have time for it in today's presentation. But it's a nice vignette of 4 families talking about their experience of using craft to influence their loved one and gain a better understanding of addiction. So one of the questions that comes up most often is the compatibility or incompatibility of craft and Al-Anon. We see that, craft and Al-Anon do share some things in common, particularly emphasis on self-care for the family members, and also a better understanding of substance use disorders. Really, the most important differences are in the areas of engagement versus detachment, engagement with the craft model and the idea of detachment as a technique in Al-Anon. Of course, Al-Anon is peer-led, and craft, or our FAMCO program, is therapist-led. And again, the overall goals are slightly different, with Al-Anon being more concerned about the self-care of the family members, and craft, or our FAMCO program, is geared towards affecting change and getting the loved one into treatment. Still, I think they are in many ways compatible. They both really are good ways for the families to gain some much needed support during a very stressful time. So our FAMCO course, Family and Concerned Others, we meet for 6 consecutive evenings. Our class is an hour and a half long each night. We have a different readings assigned each evening and go through a number of different exercises, worksheets. It's not a support group per se, like an Al-Anon group, but many family members feel that they get a lot of support just by working through the materials with other people and really hearing the experiences that they have with their loved ones. So the course is based on the book Beyond Addiction. The authors are 2 primarily psychiatrists or PhD psychologists, at the Center for Motivation and Change in New York. If you play that embedded video, that's, again, they produce that. Essentially what we've done in the clinic is break down the different chapters and concepts in the book and laid them out kind of in a fashion that makes sense, that we can walk through with the participants. Basically, the idea is to offer a new perspective on substance use disorders and that practical guidance for the families as they support their loved one in recovery. Essentially, the idea here is that with craft and with the Beyond Addiction book, treats the interaction between the family and the loved one as more or less a deficit of skills rather than framing it as the disease of codependency. And the idea is that the skills can be learned so that their interactions with their loved one can change and hopefully improve the lives of their loved one and also their own personal lives. So we start with week one we entitled the Installation of Hope. We give the family members an overview of craft so that they understand the model that they're working with. Essentially, the ideas are based on being positive, supportive, not using confrontation. We see that the family members, as they engage in the course, experience a lot of relief. They don't have as much depression or anxiety. Anger and frustration usually is reduced. And we see this even if the loved one isn't participating in treatment either at our clinic or elsewhere. So we start with some of the common barriers to treatment. First is black and white thinking that their loved one is either in recovery or in denial. One of the concepts that runs throughout the course is understanding a patient's or their loved one's ambivalence towards their use, that they see benefit in it, even if that the patient sees benefit, even perhaps if the family doesn't. So we move away from the idea of someone either being in recovery in some sort of concrete way or simply in denial. We also, at our clinic and in the book Beyond Addiction, talk about the barrier or the damage that labels have, I think, both on the patient and on the family members, that it's when we view a person simply as an addict or alcoholic, it leaves an incomplete picture of their situation and really doesn't facilitate change. We also talk again about confrontation being a huge motivation killer, that confronting someone is not a way that facilitates change. And then we talk about the facilitators to treatment. Skillful family involvement obviously is important for the support of the patient and in engaging them in the change process. We also know that individualized treatment, meaning not simply groups or a program, get more buy-in from patients and have better success. We talk with our family members about understanding a patient's use patterns, that, again, they get a benefit out of their use, perhaps even if the family is not aware of it. And understanding how and when and why a person engages in their substance use is important for understanding how you might influence the change process. One of the themes, of course, that runs throughout the program is positive communication, and that's one of the coming weeks that we'll talk about, and also the idea of reinforcing behaviors that you want in a patient or in their loved one. We also talk again about supporting ambivalence and empathy, that these ideas of understanding what's going on with the patient, with their loved one, and understanding that there's going to be continued ambivalence through the change process is really one of the most important ways to have empathy for someone. Our second week dives into the neuroscience of addiction. we use a long PowerPoint presentation put out by the Surgeon General. If any of you in the substance use realm have seen that report, I think it came out about 9 months ago. And it has an excellent executive summary that really gives a detailed explanation of what's happening in the brain when somebody becomes engaged in substance use. So we feel like that is one of the, or I should say, the family members come away from that evening and after reading that chapter in the book with a much different understanding of why the patient is continuing to engage in their, drug of choice or with alcohol. We go over the DSM criteria and review sort of what qualifies problematic substance use. We also talk about the fact that a substance use disorder is an actual disorder, and it really helps folks move away from that concept that a patient is simply engaging in poor behavior or making a bad choice. So we talk about, again, the idea that negative labels have a negative impact. It really affects how we treat people. It affects how people feel about themselves and how it can stifle the change process. We go into the idea of the biopsychosocial model of a substance use disorder that, especially for alcohol use disorders, there's a roughly 50 or 60% etiology of the disorder is pure genetics. We talk about how a substance use disorder develops over time and is influenced by the patient's social environment, and to try and get the folks to think about the impact that their patient's mental health plays in their use. For those of you who work in the substance use field, what we all see almost all the time is usually a primary or secondary co-occurring mental health disorder, whether it's anxiety or depression, might be bipolar, that these co-occurring disorders aren't necessarily caused by the substance use or vice versa, but that they are always interacting with each other. And it really helps family members to understand better what their loved one is going through. So week 3, we talk about motivation. Again, it's hard really to empathize with somebody if you don't understand why they're doing the behavior that they are. And we talk about the idea that motivation is a goal-oriented behavior. It can change over time, and that's hopefully that understanding of motivation is a way that we can use that as we influence the change process. We of course talk about the stages of change, probably all of you familiar with that, pre-contemplation, contemplation, etc. And that's really an interesting and enlightening conversation with the family members. once they understand how the change process occurs and what those stages are, they kind of gain a better idea of where their loved one is in relationship to those stages. And I think for many, it helps them, kind of come to terms with, maybe somebody's in contemplation, maybe they're not, and that we need to kind of tailor our strategies as we do, as most of us do in clinics, to where that patient is at that particular point in time. We also know that changing a behavior is difficult. It's not just a decision that somebody makes that they want to change something. It's a learning process. It involves a lot of failure, and that, practicing in real life, in real time, is really what most patients are going through out there. And understanding that change process, I think, gives family members a little more hope, a little more patience, and understanding that it is a process of change, and that change takes time. So, quick thought experiment, and we do this in the class. We ask, and I'm hoping you all can do this as we talk, or as I talk. Think back to a time when you attempted to change an unhealthy behavior. How much time elapsed between when you first started the behavior and when you recognized that it was risky or negative in some way? And then once you recognized that, how much time elapsed before you started or attempted to change the behavior? For most of us, there's a long period of time between these events. And then finally, how many slips or back into old behaviors happened along the way? So the point of the exercise in the class is to really gain some empathy for the patient, that even in all of our lives, when we attempt to change a behavior, rarely, if ever, does somebody catch a behavior that they want to change, shortly after they begin it. And when they catch it and decide to change, do they just embark on a, flawless change process? They decide to quit something, they make the decision, and then they stop. So this is one of the most interesting discussions we have during the course, because it makes this process of changing an addiction less about that idea of deciding something, and frames it in the perspective of learning a new behavior. And as we all know, learning a new behavior takes a lot of time. So week 4, we begin one of the 2 sections on self-care. Again, this is where we get a little bit of an overlap with an Al-Anon kind of perspective. The Beyond Addiction book lays out this ACT, awareness, coping, and tolerance strategy. Awareness really is for families to begin to become aware of their limits and behaviors that that are acceptable to them, things that aren't, maybe the limits of what they're willing to do for their loved one and what they're not. We talk about coping strategies, essentially the idea that during this time of change or when somebody's actively using, the goal for the person is to manage the distress, the discomfort that their loved one's use is having. And then we talk about tolerance, the idea of accepting what we can't change. And we also talk about the idea of tolerance really is just acceptance over time, that we continually come back to the idea of accepting what is without or with as little distress as possible, and that you continue to do that over time. And that, to me, is a really nice understanding of tolerance. It's not, again, just a simple decision. It's something that you come back to time and time again. Then we start talking about a little bit more of the actual strategic engagement with the loved one. So one of the, and this is where it would be very different from Al-Anon, is we do look to try and begin to influence the behavior of the patient. And rewards and consequences are one of the ways that we do that. So with regards to rewards, we ask people to think about something that's important to their loved one, something that they're willing to continue to engage in or provide, and then something that they can also withdraw if there's negative behaviors. We emphasize that withdrawing something isn't punishment. It's simply perhaps not engaging in an event or an activity with a patient if their use or their behavior is not acceptable. These things have to be fairly clear and happen relatively immediately, either being withdrawn or reinstated. We also recommend that people don't pick something that is of monumental importance for the patient or their loved one, because that really would just set up something that's emotionally laden and probably too dramatic. We also work at practicing being neutral when either, setting the stage for this or withdrawing it. One of the nice examples that Beyond Addiction provides, just to give you an idea of what this looks like, is they have the scenario where a gentleman is married to his spouse is somebody who's has an alcohol use disorder, and he's sort of set the stage that when she comes home from work and hasn't been drinking, they have a nice dinner together. If she's been drinking, he simply eats by himself or does another activity. So it's not a monumental reward. It's something that can be talked about ahead of time, explained in a very kind fashion. So the husband might say, "I'd like to have dinner with you. I enjoy it and I'm happy to prepare dinner. And as long as you've not been drinking, I want to continue engaging in that. And if you have, I'll do something, or eat on my own. So again, it's not something monumental, but it really does begin to shape the behavior of the person with the substance use disorder. I talk with the family members that all of the things that we're doing aren't, there's no one thing that's going to be the magic bullet that will open up some huge change in their loved one. Really what we're doing is kind of working around the edges in a very kind and loving way to influence behaviors that are more acceptable and perhaps ignoring or not reinforcing behaviors that aren't. So one of the other kind of hot topics in the class is the idea of natural consequences. So we start with the caveat that especially parents, really have to decide for themselves what they're willing to allow to happen. It's going to be really different for different people. Some are very willing to let natural consequences happen. But essentially these are things like, if somebody's hungover and not waking up for work, do you wake them, call their employer, do these other things that sort of soften or intervene on their behalf, or do you let them happen? Now, many families come to our class having set in motion a lot of behaviors that they wish they hadn't. And one of our goals is to kind of give them permission to change how they interact with the patients. Simply saying, to their son or daughter or their loved one, I've got into this pattern of waking you every time you need to go to work. I'm not willing to do that anymore. So you'll have to take care of that on your own. Again, this will vary quite a bit, patient to patient and family to family. So week 5 talks a lot about positive communication. The strategies, obviously, being positive is one. Being brief, don't, dump a whole lot of things on your loved one. We often find that when, especially parents, when they have a teenager, young adult who's at all receptive to their communication, they try and get everything in at once. So being brief is important, maybe just one topic at a time. In being positive, we share the idea of if somebody has a recurrence, it's much more productive to say something like, let's see where we go from here, rather than, well, now we're back to square one. So again, it sort of reframes what's happening in a more welcoming and positive light. And then label your feelings. This is the old I statements. So an example here would be, I worry when you come home later than you said you would, versus it's totally inconsiderate of you to come home late. So labeling the feelings and not trying to be so confrontational. One of the other things that's important is when you can is to offer an understanding statement. We try and coach folks to say, if they see somebody who's doing well or working hard, to simply say, I see how hard you're working on your recovery. Pretty simple. The accept partial responsibility is one that raises a lot of eyebrows. we're not talking about responsibility for the patient's use, but it's more to frame things like, hey, we're in this together. Maybe things like, I know I can get upset at times. So again, trying to make it not seem like the patient is the problem and it's this adversarial relation. So positive reinforcement seems like a no-brainer. These are just really kind of along that contingency management idea. If some of you are familiar with that, basically identifying rewards that seem important to the patient, and then suggesting that if some behavior happens, if something goes well, that it's reinforced with some sort of reward. And these can be very different for different people. It's not necessarily like big financial rewards. It might be something that the person enjoys doing. And again, it takes the conversation away from like somebody just not doing something to things that are worth reinforcing. So one of the last week of the class, we talked really more back about how the family member themselves are doing. We talk about setting goals for their life. There's a really nice graph or table in the book that's their happiness scale, where people can revisit how they're doing in their relationships, maybe with their own substance use, their health, exercise, work life, all sorts of different things, and begins to focus in on the things that the family member can control no matter what is going on with the person with the substance use disorder. Again, and part of that overarching goal there is to continue to build their own personal life, that even if a family member is struggling with the substance use disorder, it doesn't mean that somebody has to put their life on hold, because we all know that these things can go on for years for some folks, and that the health of the family actually has a positive influence on their loved one. Some of the things we talk about there are mindfulness. We talk again about goals to give them some focus outside of the patient, and then come up with a whole page of people that can help them as they struggle. So I'll just share real briefly so we have time for questions. A recent patient to the clinic just started a few weeks ago. Young man with an opioid use disorder. His parents came to us maybe 7-8 months ago. I met with them, went over the Beyond Addiction book, gave them some coaching on how they could maybe begin to influence their son. They had recently, when they found out that he was actively using, did an intervention. It went not well. The patient really stopped talking to them for a couple of months. And then when I did the last FAMCO course, these folks enrolled and came week after week. And, I worked with them on the side a little bit too. And over the time of the course and in the preceding couple months, they really changed how they interacted with their son. Gave him a lot more space, didn't push to get him into any sort of rehab, gave him the information on the clinic, and really stepped back. And while it's not guaranteed to be successful, in this case, their son is now a patient, and you know, we have some traction there that I think we wouldn't have had if he would have been kind of forced through the door. I encourage everybody to get the book Beyond Addiction. It's available everywhere. Some of the things that we don't get to discuss in the class but are covered in the book are they give folks ways to evaluate treatment options, suggestions for or strategies to suggest treatment. Also provides ways for families to understand how to interact with treatment providers. Also expectations for change as someone's engaged in treatment. And they also talk about safety. This is particular for spouses and partners if they're in situations that are unsafe. And then we do spend a little bit of time evaluating risk, especially for patients who whose families, whose patients are on opioids, and then also things like withdrawal concerns. So we have about 10 minutes. I don't know if Joe has any questions queued up yet.
Hello, Scott. Well, thank you for giving us all that great information. We have just a couple of questions to get us started here. If anyone else has any, please submit them through the chat box below. How long has Alltyr been offering the FAMCO program? I'm sorry if you covered this right at the beginning.
Nope, we've been doing it approximately 3 years or so. I've done it the last 2, alternating with one of our other therapists. So,
okay, and do families and the concerned others attend with the person with the substance use disorder, or is this a separate, for the families and concerned others? And what is the turnout like?
yeah, so great question. Yeah, I should have highlighted that. There are no patients at the class. So this is strictly parents, husbands, partners, and that's by intent. This isn't a time for, the patients and their loved ones to interact. It's an educational venue. So it's different that we do at times do some family sessions, but it's more or less guided by where the patient's at in their treatment. We've been having really good turnout. We limit the class size to approximately 20 people, and we offer it 3 times a year. Just 20 is about what we can manage as far as discussion. It doesn't take us long to fill the spots. Again, we're a relatively small clinic with 3 therapists who see probably about 30 patients each per week, give or take, just to give you a perspective on that.
All right. And is there a schedule like on your website? Do people call if they're interested?
Yeah, we begin to add, we do put something on our website about a month or so prior. Our next course will be starting in early or mid-January, and it is open to really anyone. Again, we have probably about 2/3 of the attendees have patients who are already patients of the clinic, but a good third or so have loved ones who they would like to come to the clinic or engage in some sort of treatment. So we do, you don't have to have a patient enrolled at Alltyr to attend the class.
Okay, thanks, Scott. That's all good to know for anyone interested in attending this FAMCO program. We have several other questions that have rolled in here. Taylor would like to know, or Taylor says, I know you had mentioned that you typically present the biopsychosocial model to families, but do you ever discuss the other models of addiction with these families?
The evening that we do the neuroscience of addiction is pretty straightforward, science-based. It's, what's happening in the pleasure center of the brains and reinforcement there. So we don't go much beyond that. Partly it's, again, we're basing it on the book Beyond Addiction, and more or less, keeping to what's discussed there. And of course, for time, it's really hard to offer more broader, theoretical perspective.
Sure. Bria would like to know, how is FAMCO paid for and how are referrals made? And I'm just going to loop another question in there. Is there a cost for families?
Yeah, so we try and keep it pretty affordable. The cost per attendee is $195. That's for the 6-week course and the book. People enroll basically just by contacting the clinic. There's some other part of that question I think I forgot.
Oh, how is FAMCO paid for? So do these
Right.
attendance fees
Yeah.
cover your cost then? Okay.
Right, and it's not a medical service, so it's not reimbursable by insurance. It's an educational class, just to distinguish that from a clinic service.
Sure. Dan would like to know, families live with fears like losing their loved ones. How do family members handle having these fears but not confronting family members about them?
I think family members can talk with their loved one about their concerns. If I was coaching somebody, I would say, that they could make a statement to their loved one, we care deeply about you and we're concerned about your health and safety. I think you can share those concerns in ways that aren't confrontational or overly dramatic. There's, we encourage a lot of honest, open communication. Again, the difference we're trying to get at is to do things as skillfully as possible, to keep the relationship between the loved one and the patient intact. Otherwise, if there's no relationship, you really can't influence the loved one. And again, that's really a very big difference between some more traditional 12-step models based on detachment versus the FAMCO and CRAFT model of engagement.
Great, thank you, Scott. Shannon would like to know, what is the average time it takes a patient to begin to ask for or go for help?
Well, I'm just thinking back to some of the patients and the families I've worked with, like the young man I was mentioning. It's not uncommon for the clinic staff to begin engaging with the families 2, 4, 6, maybe 8 months. I had a patient join the clinic about a year after their family took the FAMCO course. So it's often a slower process than I think families would like sometimes, but we find that when the patient does arrive, the engagement is really starts off in a different manner than if they would have been quote unquote rushed into treatment.
Sure, sure. And I'm sure there are myriad issues impacting that time frame. So thank you, Scott. Angelique would like to know, does your program work for those persons who have to consume substances so that their bodies feel better or normal? And if it does work, how so? What have you seen?
I'm not sure if I entirely understand the question, but you know, we're not an abstinence-based clinic, so we work with patients where they're at, and so we have some patients who are just interested in moderating their use. We also see patients across the dimension of a disorder, so somebody who meets 2 or 3 criteria all the way up to someone meeting 11. Most of our patients do choose to abstain, but it's not a requirement. And if somebody really has a need to ingest something, well, one, we're a Suboxone clinic for opioids. The other piece would be we would maybe find out why they need to do that. Is it untreated ADHD or some other way that they could have a more medically based intervention than an illicit substance.
All right, thank you, Scott. And one final question, Margaret would like to know, what other family support or education programs are you aware of in the community? Does Alltyr offer any other such programs?
No, this is what we offer. We also have an LMFT in the clinic as one of her clinical licensures, and we do some family therapy via that and couples therapy. Nothing else comes to mind. I mean, most rehab centers, you know, traditional rehabs have family programs that concur with the patient's enrollment. This, again, is more of a standalone program, and it doesn't matter if the patient's enrolled at Alltyr or not.
All right. Thank you, Scott. And I'm sorry, do you have time for one more
Sure.
question?
Sure.
Sherry says, I find it interesting that you talk about detachment not being engagement when detachment is a means to engagement. Could you please explain what you believe the definition of detachment to be?
Well, if somebody's speaking more or less about emotional detachment, I would say that is a means towards more positive engagement. In other words, lowering the emotional, kind of the emotional level that's going on between the loved one and the patient. So in that case, for sure, having that emotional distance aids the interaction. I think of when we think of detachment as more or less no engagement, no conversations, something a little more concrete.
Okay. Well, thank you,
So yeah,
Scott.
great question.
Yes, and thank you. I'd like to thank everyone for your great questions this month today, and I'd like to thank you all for joining our webinar, and an extra special thanks on behalf of MinCam for our former MinCammer, Scott Brownlee. He was here when I started, and
Yeah.
we're all just thrilled to see him go on and affect positive change out in the community. So thank you all, and thank you, Scott.
It's a pleasure, Joe. Thank you all.